let everybody know. Yes, you're being recorded and we are recording now. Okay, more. We are doing that. Is that doing? Why does it always do that?
I don't know why, but that one you clicks the buttons doesn't move. The other one.
Share, hold on. Do you know PT monitor? Oh no, not that one. Share. That one. That one.
Can you make that into a slideshow from the No.
Oh my god, it was working before. Oh, I don't want to stop sharing. Just share. Resume slideshow. It's 2 seconds.
Yeah, but that other window is the slides. The one on the right, on the far right.
That one.
Yeah. So when you do that, it does actually allow.
You're sharing your screen. Okay, that's what we want to do. So.
So that one is nice to know is the
Okay.
slides move.
We just need to get that.
Oh, there you go. Is that the idea?
Oh my gosh. There you go. Why not? Are you happy with that?
Yeah, it'll work.
They can still see that and they can read that. It's got your display. Oh, that's the next one up. No, that's the only problem. Not yet, but they might come in, you see. So, and I need to record it anyway. Yeah. So we are recording.
Yeah. You can always edit this one bigger.
We can, yes, that's right. Share. We just don't really want that next slide up, do we? Display settings, swap presenter view and slideshow duplicate. Yeah. Any techie people here? It's just no, that's not. It was all working and now it's not. But that's
stop right. Ah, what have you done there? Done something that works.
I don't know.
Okay.
Are you happy with that one?
Yep. That'll work.
That'll work.
Okay.
Pop you down here.
All right.
Hang over there. Just have your little head pop.
Okay, so my head will pop in the corner. That looks all right.
We're recording.
Okay. Well, we're off.
We're sharing your screen. We're recording.
Working.
Hey, straight in.
Hang on.
Joe,
that does work. Okay. Sorry about the delay, folks, but I don't know anything about technology, so away we go. So thanks for coming out tonight. First up. So yeah, we're going to talk about chronic pain and medicinal cannabis. So I'll introduce myself in a moment. First up, just who's in the room? We've got nurses, hands up, doctors, physios, OTs, psychologists, students. All right, what am I missing? Who?
Social worker.
Okay, sorry.
Paramedic.
Okay.
Exercise.
All right. Got to get a better list. Sorry. Okay, close. All right. So that's me. I'm a GP. Probably for the purposes of this talk, yes, I'm a medical consultant to Little Green Pharma, which is a medicinal cannabis company. And yes, it is a paid role, pays enough to keep me working as a doctor. And yes, I am board member and in fact vice president of Arthritis Foundation, and that's under their banner that I'm here this evening. And I've got my own podcast for those who are interested and want to like and subscribe and share. Please do. It's on Spotify and YouTube and all the other channels. So that's the plug for me. So a little bit about the Arthritis Foundation. They do run self-management programs and health professional education. So here we are tonight. And also public education and community. They run a camp for juvenile arthritis for 7 to 17-year-olds and what's called transitional 18 to 35-year-olds. Typically, we generally tend to think about arthritis as a condition that affects older people. And yes, it is more common in an older age group, but juvenile rheumatoid is a thing, and there are some other forms as well. A lot of consumer support groups, telephone support line. They do find that the demographics, not the younger ones, but the older people, still like to talk to somebody on the phone, not necessarily a chat box online. Roll for that too. And yes, they present at seminars and expos and have information packs. The headquarters, that's a pick from the offices at Shenton Park, where, yes, there is a hydro pool and that gets used quite extensively. And there are also land-based programs that are run, and there are programs run in regional centres. And it's one of my something that I've been pushing at a board level, that we need to do a little bit more in regional areas than we have been doing. But obviously, that's a work in progress. All right, so that's a bit of a plug for the foundation tonight. So from this point forward, I'm not expressing views on behalf of the Arthritis Foundation. These are my personal views. So I'll hopefully understand a little bit about chronic pain, and particularly chronic non-cancer pain, and also a little bit about the role of medicinal cannabis. And you've probably seen it's been in the media recently for all the wrong reasons, and we'll touch on that as well. And look, there are some local issues, and it's not for me to come and tell you how to run things locally, but anywhere around the state. I've been down to Albany or in Kalgoorlie earlier in the year, and it's worldwide. Regional areas are typically neglected by capital cities, and it's a fact. And it is hard to get people to come up to country areas. And again, that's not just restricted to Australia. Anywhere I've been in the world, you look at newspapers and you find the same issues. That's just a societal issue. And telehealth has been a plus. It has its limitations. It's got its problems, but it also has its pluses. And if there has been anything good come out of the pandemic response, for years they've been lobbying to say we should be able to do some consultations by telehealth, and it was finally allowed. And that also enables some degree of collaboration. So you can get in touch. It's more easy, or easier perhaps, to get in touch with people and get input from other practitioners if they don't physically have to be present. Now, if they can come up and run clinics, it's probably even better, but it doesn't happen as often as I'm sure you would all like. So linking in through telehealth can be helpful. And that includes for education. And I think we've got a few people online tonight who aren't in the room. And there are also technological solutions for prescription monitoring these days. So some of you might not be familiar with that, but if I want to prescribe a Schedule 8 medication, which is a restricted one, a little dialogue box comes up on the screen, and we'll have either a green, yellow or red box. And if it's a red box, I need to log into the health department system, and it'll show me how much and from who. People may have got other prescriptions, and that's now mandatory in all states and territories. And that is a useful thing, and includes monitoring of basically any Schedule 8. So again, upskilling is helpful. Telehealth is useful, and access. And again, I don't know whether there are or aren't. We'll get to the medicinal cannabis part later. I don't know if there are any prescribers in Broome or not. There are some telehealth clinics. Some are very good, some are not, and they're the ones who've been getting attention. Rightly so, a little about 2.5 years late, but you can argue better late than never. Okay. So chronic non-cancer pain is defined internationally as pain that lasts for 3 months or more. In Australia, 3 of the past 6 months. Now, why we need a different definition to the rest of the world, I don't know, but there it is. And it could also be defined as pain that lasts longer than expected following surgery or trauma or some other reason. And I think, like a lot of things, we can probably recognise it. Sometimes putting it into words is a little bit more difficult. When I was a med student and we were doing a surgical term, I remember, this is showing my age now, we asked the surgeon something and he said, guys, can you tell the difference between a Holden and a Falcon? Cars, some of you probably won't remember them, but that's all right. Maybe a Hyundai and a Toyota. And we all said, yeah, we can tell the difference if we see them. Right, we'll describe the differences in words. Could anybody do that?
The logo.
Yeah, the logo. But aside from that, look exactly. Oh, they've all got doors, they've got a boot, they've got a bonnet, or a hatch, and windows. So you can recognise it. And yes, you're right about the logo, but even without the logos, people who know cars can recognise it. But describing the differences, not so easy. It's common. 20% of females, 70% of males, roughly 1 in 5 Australians, interferes with function in 1 in 5%, so 1 in 20 people. And surprise, surprise, more common in lower socioeconomic areas. That's not a function of income per se. It's typically more a function of what people do. So if you are working at a desk, at a laptop, you're probably less likely to suffer an injury than if you're working on a building or a construction site. And if you're more likely to get an injury, you're more likely to suffer pain. Not to say people can't get neck or back pain sitting at their desk, but it is less likely. And surprise, surprise, it increases with age. And again, that's a function of more likely something may happen to you, but also we're getting into degenerative problems. Yes, they are more common in an older age group. Stephanie Davies, the pain specialist in Perth, she had a really nice definition of chronic versus acute pain. Chronic pain is pain plus threat. So there is a psychological component with chronic pain for most people. That's not saying that it's in their mind or imaginary, no, but there is a psychological component and some sensitization. Now, has anybody seen or watched Dope Sick or Painkiller on Netflix? Yeah, okay. Yep. If you haven't, either of those are worth seeing. Anybody familiar with Purdue Pharmaceuticals? Anybody heard the name? Okay. So in the 1990s, this comes out of America, and rightly or wrongly, we tend to follow America. We used to be a British colony, now we're really a bit more an American colony. Became the 5th vital sign, which is a nonsense because it's not a sign. What's pain? A symptom. Yeah, it's not a sign. So your breathing rate, your temperature, your pulse rate, and your blood pressure are signs. They can be objectively measured. Pain cannot be objectively measured. It's been captured, you can do a questionnaire, but it cannot be objectively measured. So it is not a sign. And the aim, and it's lovely, eliminate pain. Fantastic. I'd like to eliminate poverty as well. But not necessarily going to happen, certainly not in our lifetimes. And in the late 1990s, oral opiates came into being. They were not in existence before the late 1990s, and they were promoted by Purdue Pharmaceuticals and others as non-addictive. Surprise, surprise, they were addictive, and this is where these programs come in. So in 2008, this is about 9, 10 years down the track, Purdue Pharmaceuticals was fined by a court. The FDA in America took them to court. They were fined $632 million US. To put them out of business? Cost of doing business. They didn't like it, rather not pay a fine, but didn't stop them. And that was for false promotion. And by then, the genius, to say, was out in the bottle. It took another decade, about 2018, 19 or so, for finally settlements to be reached in America. And yes, they did introduce some tamper-proof tablets, and yes, some other changes were made, and things are better, although the fentanyl issue with the border being opened created its own set of problems. And we, as we tend to do, followed suit, and we've also had an increased number of overdose deaths from opiates. And you can see the numbers there. 1999, less than 20,000 overdose deaths in the United States, going up to over 100,000 in 2021. About 2,000 overdose deaths in Australia every year, far more from prescription medications than from illicit medications. You wouldn't think so by listening to the media, but that is the case. It's more than the road toll.
Is there any
As in accidental versus deliberate? Good question. I don't have the exact answer to it. And it can be very, very difficult to know. That's from America. Australian statistics for overdose, it's around about 1,800 to 2,000 a year. It hasn't been a steep climb in the same way that in America. And in 2020, they did change some of the prescribing laws around, prescribing regulations, perhaps, around opiates, in that repeats couldn't be issued for medications like tramadol, which they used to be able to. And that has plateaued a little bit in America. They're starting to see that leveling off. But yes, how much is deliberate and how much is accidental? I don't think anybody's been able to work that out. It's a bit like with the road toll. How many single car collisions with trees are suicides versus actual road fatalities? Nobody knows. So credit to the Faculty of Pain Management. They decided to take an approach which was classed as psychosocial rather than strictly biomedical, and essentially saying we can't just look at pain in a biomedical model that says if we just do enough scans, we'll find an answer and then we'll treat it. There are a lot of other social, psychological and societal issues that do come into play and needs to be sort of recognised. Now, recognising them is not the same as saying we can fix them, but we can recognise them and at least look to address them as best as possible, understanding that a lot of things are not fixable. There are different types of pain. 20% is neuropathic pain, so that's nerve pain. So, for example, sciatica or trigeminal neuralgia or post-herpetic neuralgia, if anybody's ever had shingles, that would be neuropathic pain. Nociceptive pain is often where there's been some sensitization, so fibromyalgia might be an example of that. And yeah, there's lots of different types of pain: back pain, neck pain. I won't read all those out, but it gives you some idea. Diabetic neuropathy, when people with diabetes, particularly in the feet, get pins and needles or pains in the feet. Again, that's from damage typically to the nerves. And as I said, 1 in 5 Australians with severe or very severe pain also have depression or other mood disorders. And that makes sense. I mean, if you're in a lot of pain, it's generally going to make you feel fairly down. So it's probably not a great surprise. A lot of money spent, 4.8 billion per year. It's probably more than that. I put these slides together about 18 months ago. It's probably more than that now. And a lot of money spent on treatments that don't work or potentially do harm, and that includes some surgeries. There's a role for surgery in back pain. We're doing less of it now than we did in years gone by. But unless there is some structural issue that can be addressed by surgery, surgery is not particularly helpful in back pain. Yoga actually has an evidence base. It doesn't receive a subsidy. Anti-inflammatory medications, so things like diclofenac, naproxen and others, where there is no evidence in back pain. Now, they do have an analgesic effect, so if you take an anti-inflammatory, and that includes ibuprofen, it can help with the pain, but it has no treatment effect. Almost everyone will have some low back pain at some point in their lives. Yes, it does increase with age. It's gone up significantly since 1990, and that could be a reflection, a bit of an ageing population, could be a function of better recognition, it could be a function of people being more likely to come forward and talk about it. So, a little bit, yeah, that's probably a factor too. It's getting more prevalent in lower and middle income countries, so that sort of suggests that maybe there is an industrialization effect, so people getting out of the fields and, as you said, getting more into offices. Exactly why that's the case is not always clear, and interestingly, how you get treated can be a function of where you are, which I always find fascinating in medicine, that your geographic location may be a function in how you get treated. So it could be some countries more likely to get surgery, some you might be just told to go and rest up, some you might be given medications, particularly in South America. Medications, people really think if they haven't got a prescription for a medication and they can't see the doctor, there's something wrong. Again, so lots of different approaches. And I said before, a biomedical approach is not likely to help. So doing more scans when all the previous ones have been normal is not really going to assist a lot. And it also reinforces the idea that there is something wrong. And yes, there's something wrong if you define it that yes, there is pain. Doesn't mean there's any structural abnormality. So anybody ever had a headache? Yeah, yeah. We could do 50 scans of your brain. We're not going to see anything, but it still hurts. Migraine, probably a classic example of that, but a classic, 101, just frontal or tension headache. It's going to hurt, but you're not going to see anything if you do a scan. Same with blood tests. So there are different ways of classifying pain, and yes, we do need to look for causes. We don't want to assume that there isn't anything structural, but there are pointers, and we can look for what else might be going on, and that could include other underlying conditions. Psychological conditions can affect it. So obviously, if people come along to the doctor, they're going to need to have a physical examination, and there is a role for tests depending upon what's been found so far. There's a lot of things that affect people's pain's perception, and pain perception is also obviously related to pain, but how people perceive pain and what they make of it is different from person to person. And probably the best example of that is you look at professional sports, and people can endure quite a lot of pain and keep playing and keep going and don't want to stop. Much less pain than that in a domestic or work situation may see people stop immediately what they're doing. So where people are at and how they feel about it has an enormous impact. So if you think that pain is harmful, disabling, and look, in some instances it can be, but in some instances it isn't, so it's not necessarily going to be harmful, might be pleasant. I'm not saying it's pleasant, but that's different to harmful. People then avoid activity, and if you avoid activity, it's going to make it worse rather than better and become self-reinforcing, and the people get withdrawn, and that increases psychological problems. The idea that passive treatment is going to do it. So, for example, I just go along to the physiotherapist, they're going to fix all my pain, and I don't need to go away and do the exercises. Not going to help. And the idea that if I just get stronger painkillers, that's going to help. Well, we've seen how that's ended up, and it doesn't end up well. And yes, if there is a pot of gold at the end of it, that doesn't necessarily help either. I'm not saying people are malingering or making it up, but if there is litigation involved, it doesn't necessarily help the recovery. We're not always going to cure pain. The aim is to make it better and as good as it can be, and to get people as engaged in their life and as back to normal as it is possible for them to be, whilst recognising that that may not be a perfect outcome. So we're looking at the physical, emotional and social functioning, so getting people as good as they can be, rather than saying, yes, we're going to get rid of all your pain. So this 90s notion of elimination of pain, I'm pleased to say we've moved away from, and it's important to, in talking to patients, being upfront with that at the start. Like, we hope your pain goes away. That will be great, but we can't necessarily say that that will happen or when it will happen. But in the meantime, we've got to make you as good as you can be. And that includes treating other issues. If there is depression or other mental health issues, they may need to be treated. Goals, and that includes self-management. So yes, passive treatment by itself is not going to fix it. So there needs to be some active treatment, and that's going to include different types of exercise or stretching. Can include relaxation techniques, including mindfulness, breathing, meditation, and there's a variety of different approaches. So treating the psychological as well as the physical. Non-opioid medications, if we're going down the medication line, is first line. That includes paracetamol, and there is a role for anti-inflammatories in terms of pain relief rather than treatment. We're not treating the underlying problem now. For example, people have got rheumatoid arthritis and active inflammation, then they may benefit from an anti-inflammatory medication. They may be on the medium term. Some of the older antidepressants, amitriptyline in particular, can have a role. It's sort of like what they call a pain scrambler. It sort of like creates a bit of white noise, so you can't hear the sound, to use that analogy. Can cause some side effects, dry mouth. It can cause some constipation. It's not always that popular. A couple of the newer antidepressants, duloxetine and venlafaxine, have got some role. The SSRIs, I suppose you're familiar with fluoxetine, Prozac and its ilk. There's quite a few of them. They've got no analgesic effect. Gabapentin and pregabalin have got a role. Pregabalin has also got its problems and can be addictive. Was used excessively for a period of time. I think it's now a little bit back in its box, and it does have a role, but again, more for nerve pain, certainly not for orthopedic or musculoskeletal pain. Carbamazepine is another anticonvulsant. It has a role in trigeminal neuralgia. I've seen it used in post-herpetic neuralgia. These ones were a little bit of trial and error. These are all what we call off-label. So they're not designed for that purpose, but they've been found to be useful. And then in saying to people, look, you can try this, and there's a couple of possibilities it's going to help you. And if it does, great. If it doesn't, we don't continue with it. And look, there is still a role for opioids, but very short term, and they need to be quite defined. So if there is an acute exacerbation, maybe we're using them for a week or so. In a post-surgical setting, yes, opioids are going to be used, and hopefully people get out of hospital and wean off them very, very quickly. We have improved our usage of opioids. And there's a lot of treatments that don't involve pharmaceuticals. And again, education, so people can understand what they're going through, which again helps with the idea that it's harmful. I'm going to die of this. No, I'm not going to die of it. It might not be pleasant. We can make it better. So understanding that, because people sometimes have their own ideas about what's going on, and sometimes they're quite correct and sometimes they're quite incorrect. Exercise, we've touched on, really, really important. It makes a massive difference. Physiotherapy does have a role. There is a role for, physio or massage, or, people like chiropractic, whatever their preferred modality is. People have their preferences. Counselling can have a role. There can be behavioural interventions in different age groups. Home modifications, shower rails, shower chairs, guardrails, non-slip mats. There's a lot that can be done to help people, again, settling cases where it's an issue. If there are aggravating factors, if they can be modified, that can be helpful too. So it's a bit of a menu selection. Not everything there is applicable to everybody. Again, it's about looking at what is applicable to the individual. And yes, it can sometimes be not so much trial and error as much as, well, we need to go down this path, see where it leads us, but not be fixed. And we may need to change tack if we're not getting the success. The aim is to improve quality of life. I think that's a really big difference between improving quality of life and eliminating pain. Reducing pain, making it more bearable, getting them through the day. We want to minimise the risk of harms, and that includes not just lethal overdose, but side effects. Improve control of pain, and again, improve not being the same as eliminate. If there are other issues, and that could include diabetes, then managing that as best possible, and encouraging people to engage with life. So not getting withdrawn and stopping activities. If people get socially withdrawn and stop doing any form of exercise or activity, then they will get worse both socially and psychologically. And look, despite all and everybody's best efforts, that still does happen sometimes. It's not a perfect world. So chronic pain is very common. There has been, since the late 90s and probably for the best part of 2 decades, a reliance on pharmaceuticals. Not anymore. It is individualised. There's no one size fits all. We've got a range of different approaches that can be used. And as I said, it's getting people back to an optimal quality of life in terms of their work, relationships and social engagement. Get them to be as best they can be given the circumstances they find themselves in. And look, there are some courses. University of South Australia has a course on pain sciences for those who are interested. All right, so this is the part of the talk that usually people have come along for, and no, there's no samples. So medicinal cannabis is new. Yeah, actually, it's not. This is fascinating when you delve into the history. So up until the earliest part of the 20th century, medicinal cannabis was used in a lot of countries. The University of Western Sydney has done some work that shows use of cannabis going back 5,000 years. I don't know how they work this stuff out. But in the United States and in Australia as well, forerunners of what today Pfizer, I presume everybody's heard of Pfizer, and Eli Lilly, had medicinal cannabis products that they manufactured. They were prescribed by doctors, dispensed by pharmacists, taken by patients for very similar reasons to what are used today. And this is still about the 1920s and 30s. And then something changed. Now, this next slide, I'm going to forewarn you, is somewhat confronting, but it is really important, because if we don't learn from history, what's going to happen? Exactly. So, who's heard of J. Edgar Hoover? Anybody heard of J. Edgar Hoover? Yeah. First head of the FBI, position he held for, I think, best part of 40 years. Most people probably have not heard of Harry J. Anslinger, his contemporary, who was the first head of what is now called the DEA, or Drug Enforcement Agency. It was then called the Federal Bureau of Narcotics. And Anslinger was a prohibitionist. And as we all know, in the 1920s, America, alcohol was prohibited. Very, very good for the mafia. They did extremely well out of alcohol prohibition, phenomenally well. Nobody else did very well. And Anslinger was a prohibitionist. And when you're a prohibitionist and you're about to be out of work, what's the best thing to do? Find something else to prohibit. And cannabis was it. And the Marijuana Tax Act of 1937 was pushed by Anslinger, and he convinced Congress, and you can see there, it was all about race relations. Years later, not a lot has changed. But like a lot of these characters, he was apparently very persuasive. He faced opposition from the medical lobby and the pharmacy lobby and the pharmaceutical lobby. The pharmaceutical lobby weren't quite as powerful as they are today. And Anslinger carried the day. He also had J. Edgar Hoover on side, and Hoover was very persuasive. For those who are interested in the history, you can find this online. It's a fascinating story. And the act was passed, and the rest, as they say, is history. And then in the 60s, there was renewed interest in cannabis. The Nixon administration declared the war on drugs, also tied in a little bit with race relations. Was felt that people who were opposed to their administration and the Vietnam War would be more likely to use cannabis. So you couldn't jail people for being opposed to the government. At least in those days, you couldn't. But cannabis use was a bit of a proxy. In the 90s, notwithstanding that, the first US state legalized medicinal cannabis, and I can't remember off the top of my head, it was Oregon or California. We now have 49 out of 50 jurisdictions in the United States have some form of legalized cannabis, and that's from CBD alone, and we'll touch on the two cannabinoids a little bit later, right the way through to adult use in 25 states. Now, when there's an election in America, like we hear about the presidential election, we hear about Congress, but they also have in most states propositions, which are like referendums. It's actually quite good. And if a proposition gets up, and it can be put up by citizens, if it gets up, then it will be generally be adopted as law. And typically, whenever a proposition goes up to relax the cannabis laws, it gets passed, which is why so many states now have legalized adult use and most have medical use. It's still illegal federally. So the difference in Australia is you can take cannabis, medicinal cannabis, across state lines. In America, you can't take it across state lines. But seriously, cannabis use in America, notwithstanding that it remains illegal federally, is legal in a large number of states, in fact, and in Europe as well. We're in, anybody been to Europe in the last few years? Yeah, if you go to Prague, I mean, like, seriously, there's a cannabis store on every street corner. It's really quite an eye-opener. Barcelona had quite a lot of shops. Thailand, obviously Europe, part of Asia. In Thailand, they used to shoot people. Sorry. And okay. Oh, that's true. Yeah, actually, we were told an interesting story about that too. It was basically done to try and clean up the heroin problem, we're told, in the 70s. It's one of the reasons that they've sort of encouraged cannabis. Yeah. Yeah. Yeah, I've also got a cannabis shop on almost every street corner, and I think they've
as a cheap country in Asia, they've lost popularity. They legalized cannabis.
It's gone a little bit out of control.
Insane. That they've taken it to a whole different level.
Yeah. UK, Canada, New Zealand. I mean, like at some point in the next 20 or 30 or something years, we'll probably be back to where we were in the 1920s. Human body has its own endocannabinoid system. It's probably something that's still not taught, I suspect, in medical school. The body has its own endocannabinoids. There are two 2-AG and anandamide, and they're manufactured by the the body's cells. They get broken down, they have a receptor mechanism, and you can see the areas they influence pain, appetite, digestion, sleep-wake cycle, mood, mental health, and inflammation. And those are the areas where we use medicinal cannabis. And you can see the body has receptors for CB1 and CB2. Let's see if I can. That's better. CB1 and CB2, pretty ubiquitous throughout the body. It's not working now. Oh, there we go. There's my favourite little pet hobby horse. You'll hear groups like the AMA say there's no evidence for medicinal cannabis. Well, PubMed, which is the world's largest repository of medical studies, has over 10,000. And some papers are better than others. There's a lot of crap medical papers out there. It's estimated that 85% of medical research is garbage. I think that's probably a conservative figure. But if we want to have arguments about the merits of any individual study, we can do that, but it's a very different argument to saying there isn't evidence and studies out there. Society of Cannabis Clinicians, which is a Canadian site, has over 1,200 articles, some done by their own members. And again, don't take my word for it. Go onto PubMed, put in medicinal cannabis, and you can bring up the studies. The Cochrane Collaboration is the world's largest assessor of studies. They don't conduct medical studies themselves. They look at what's out there and make assessments based on what's out there, and found or concluded that cannabis-based medications were better than placebo in reducing pain intensity, sleep problems, and psychological distress. Now, normally in medicine, that is the hurdle to jump over. How does a pharmaceutical company get its drug licensed? Well, apart from not causing major side effects, it has to be better than placebo. And that's what's the case with cannabis. So when groups say there is no evidence, well, there's no more or less evidence than for a whole lot of other medications. And that's not the same as saying that it works for everybody. It doesn't. Nothing does. If there's one blood pressure medication that lowered everybody's blood pressure, we'd only have one on the market instead of 60 or 70. If there was one SSRI antidepressant that works for everybody, there'd be one, not a couple of dozen. So the two main cannabinoids are THC and CBD, and yes, THC is the one which, if used in high enough quantities, does create the high. The CBD does not create a high. It's not psychoactive. No matter how much CBD or cannabidiol you take, you will not get high. And CBD can offset some of the effects of THC, which is why it's not popular on the black market, but very, very useful in the medicinal sense. Because THC, like any painkiller, can cause some people to be a bit foggy or woozy or a bit sedated. Now, cannabis is not a lethal substance. If we look here, alcohol 1 to 10, codeine, what you get in, say, paracetamol and codeine, for example, 1 to 20, Prozac or fluoxetine 1 to 100. So 1 is the effective dose, however you define that, and 100 in the case of Prozac is the lethal dose. In codeine, 20 times that amount, in cannabis, 20,000 times that amount. So you need to take about 20 or 25 kilograms of cannabis as a lethal dose. Straight up. Probably not likely to happen. Now, when we were in Derby last week, somebody did raise the issue that cannabis is found, and it's quite correctly, if particularly celebrities and they do the toxicology, they'll often find THC in there. That's not what's killed them. And somebody also raised the point that there was a coroner's report, I think in about 2007, I think he said it was, I could stand corrected, that indicated that cannabis was a contributing factor to suicides in the Kimberleys. Now, I haven't seen the report. I think it's likely the case that, Sarah, do you want me to admit whoever's in the waiting room? It's come up somebody waiting in the lobby. So can I just press admit? Is that all right?
Just admit something.
Okay, there we go.
And then tell him he's loud.
That's probably not for me to do. So is it possible that people who've committed suicide have used cannabis? Yeah, I think it is. Does that mean the cannabis has caused them to do it? No. Might it be whoever's out there, can you put yourself on mute? That would be really nice. Could it be the underlying reasons that have caused them to use cannabis that might have contributed? Yes. In fact, I've heard some arguments, and I'm not expressing an opinion on this, even with the cannabis use in schizophrenia, that yes, excessive cannabis use can contribute to the development of schizophrenia, but there's a contrary view from some psychiatrists that people with emergent symptoms of schizophrenia gravitate towards cannabis because it makes them feel a bit better. Something like 80% of people with schizophrenia smoke because the nicotine has a calming effect. But I like to say these things because it goes against the narrative. I didn't say that. And yes, it can be addictive, particularly if you use too much of it too often for too long. But weight for weight, it's less addictive physically than caffeine or alcohol. So again, does it need to be treated with respect? Yes. Can it be addictive if used incorrectly? Yes. But weight for weight, it is not a highly addictive substance. And that's why people drop in and out.
Are you talking physically?
Yeah. Okay, so can people become reliant on it? Yes. And same with alcohol. Something like 90 to 95% of people who drink too much are not alcoholics in the sense that they physically need a drink. They just drink because they drink. Yeah. Yeah. So. Yeah. So can people become reliant on it? Yes. And might they become reliant on it because it relaxes them? Yes. And then there's you can get into a whole sort of philosophical discussion about, self-medicating. Is that a good or a bad thing? And so it could be a whole discussion in itself. But for what it's worth, my personal opinion, not speaking, people do find and not entering into the legalities in this either, so I'm not advocating for it, obviously, but I think there's worse ways for people to calm themselves down if they can control what they're doing. There are side effects. Everything has side effects. Typically, they are fairly mild, but there's no medication without side effects. Drowsiness is probably the commonest one. Some people do feel a bit lightheaded. Some people do get a bit nauseated. THC can cause anxiety. CBD typically alleviates anxiety. And there's some people for who it's not suitable. Pregnant or breastfeeding or planning to do so. Unstable heart disease. Somebody's had a heart attack last week. This is not the week to start them on the medicinal cannabis product. Psychosis, particularly active psychosis. Prior mood disorders. Also probably THC is a no-go zone. There are people who may have had past history of psychiatric illness where there may be able to be THC used, but it's very, very much on a case-by-case basis. And in my experience, I'll always have a chat with the psychiatrist. Two main forms are vaporized, which is inhaled and taken orally. Orally are oils, so liquid forms. There are now increasingly pastilles or gummies, which are chewable. Sort of 2 years ago, there were very few of those. There's now quite a lot more. Vaporized is either flour, which people put into a vape device, or vape carts, which are preloaded liquid, which can just be used as inhaled. Vaporized gets into the body a bit more quickly, gets out more quickly. Oral gets in a bit more slowly, stays around for longer. So that's useful for chronic pain, for trying to get off to sleep, or for breakthrough pain. The vaporized can be useful. There are two overarching requirements for somebody to be able to be prescribed medicinal cannabis in this country. One, it makes sense, a condition where it can help, and studies exist, and the TGA, or Therapeutic Goods Administration, has in its portal for prescribers a list where you can just menu select. And number two is that other treatments have either failed to help or caused unacceptable side effects. There's no set number of other treatments. There's no defined level of side effect. That's a clinical judgment. That often people have been on fairly long lists of medications. I find people with chronic pain been on multiple medications. They've often had injections. They've been to physios. They've sometimes had surgeries and they're still in pain. There are lots of products out there. Way more products than we need. There are some issues with regulation, in my personal opinion. There are too many imported products coming in. We don't need 1,000+ medicinal cannabis products. We really don't. But there we are. So in terms of selecting a product for prescribers, what are we actually treating? And sometimes we're treating more than one thing. We might be treating pain and sleep problems and anxiety, which is the predominant one. Which ratio of the two cannabinoids to use, and that's the determining factor for prescribing. Should it be oral or inhaled? And there are some creams that are going to be coming out in the next little while. Internationally, there are pessaries and I think suppositories as well. There might be some contraindications. There might be reasons why people can't use it. And for example, FIFO workers who are subjected to random drug workplace testing cannot be on a product with THC. It is discriminatory. Nobody should be driving or operating machinery if they're impaired in any way. But that people may be on medicinal cannabis rather than an opiate or pregabalin or an SSRI or a benzodiazepine, which can also, an over-the-counter antihistamine for hay fever, all of which can make you groggy or tired. If THC is detected in the system, people can lose their license or lose their job, and that is discriminatory. In Tasmania, the laws are a level playing field. So if you're impaired, it's a problem. But if you're not, that they can detect it. It doesn't cause problems in Victoria. They've changed the laws. There was an upper house, committee looked at this in the previous parliament. Brian Walker, who's a doctor by profession, is a GP, lovely guy. Leader of the Legalised Cannabis Party. He spearheaded the inquiry. They made recommendations along the same lines. Gathering dust somewhere. If people have used cannabis illicitly, and a lot have, and often not to get high, but because it helped with their sleep or pain or anxiety or PTSD or other symptoms, it can also be a useful pointer. There's an international dosing guideline, which is simple: start low and go slow. You don't start at a high dose, you start at a low dose, and you just gradually notch it up. The equivalent would be, you don't turn the hot tap on in the shower full bore and then jump in and think, oh, that's a bit hot. Let's turn it up a little bit. And typically starting, with as little as 2.5 milligrams of THC. Now, in that situation, one does have to say to people, you're not going to get an instant effect. You're not going to necessarily feel better tomorrow. It's going to take a little while. So people do need to be aware of it, and it may take a few weeks before they can really gauge how they're going. Look, in terms of monitoring, look, typically good to get people back after a few weeks. Not much point asking them to come back after a couple of days. Nothing's going to have happened. And then, as with all things in medicine, the longer people are on it, the more stable they are, the less frequently they need to be seen. And, obviously an assessment that includes any side effects. Cannabis is metabolized through the liver and excreted through the kidneys. That's why it shows up on urine testing. It doesn't damage either of those organs. Just needs to be adequate function. There are 5 categories through the TGA, and you can see category 1 is predominantly CBD, so that's a Schedule 4 medication. So it's not a monitored substance. Categories 2 to 5 have varying amounts of THC, so you can see category 2 is predominantly CBD, category 3 roughly 50-50, category 4 THC dominant, and category 5 high THC. And there are a lot of the flower products, and that's the one where there's been some problems with some prescribing practices. There are 3 systems for prescribing medicinal cannabis. There's the SAS, or Special Access Scheme B, where a doctor will apply. So for the individual patient, go into the TGA, apply to prescribe medicinal cannabis for that person. They will get back approval for that person. An authorised prescriber has capacity to prescribe for people without individual application, and then report. So that's what I do, report to the TGA every 6 months the number of prescriptions that you've written. And the third one is a bit of a mezzanine level. So this is a case study, just to give a bit of an example of use of medicinal cannabis. Very stereotypical case. 76-year-old lady, she's got osteoarthritis of the neck, back, and both hips and both knees. She's got airways disease, Parkinson's disease. Yes, heart disease, but it's stable. Top level there is her current treatment. So she's on a couple of painkillers, paracetamol and pentadol, levodopa and benzodiazepines of Parkinson's. These ones are for the heart. And she's been on other pain meds. She's had long and short-acting oxycodone. She's been on tramadol, anti-inflammatory. She's had hip replacements on both sides. This is where people have really come to look at medicinal cannabis often seriously as a last resort. Probably the further we go, the more people are thinking about it, maybe not just and somebody doesn't have to be on all of that to come to it. Yeah. No, far away. Yeah.
So why is it the last resort?
Okay, so
After dinner,
yeah, okay. All right. So I suppose where we're at now is no, they don't have to have been on all of those. Like somebody in that situation, if they'd had, for example, hip replacement and maybe been on some tramadol and a couple of anti-inflammatories, that would be sufficient. As I said before, there's no set number of treatments or set level of side effect that has to be reached. So no, it doesn't have to be after all of that. There needs to be something. Probably at the other end of the spectrum, no, I've stubbed my toe, it's a bit sore, can we use medicinal cannabis? No, we can't. But no, one doesn't have to have gone to that level to qualify, no. But I mean, I use this because this is obviously de-identified but these are the sort of cases we see, and there is still it's lessening. There's still a degree of probably stigma, if you like, around medicinal cannabis, and particularly in an older age group, they're a bit wary about using it and considering it. So that is less now than a few years ago, but still an issue. Okay, so this is very much abridged to sort of make the point. And just in terms of, so we saw before the SASB application that would need to be put in. So yes, long history of chronic pain, other treatments have failed or caused side effects. And look, and she's a perfect candidate for equal parts of CBD and THC. Main reason, it's the formulation that's most likely to help and cause the least amount of problems. Could you use a higher THC? You could. It might be a little bit more potent, but more likely to cause drowsiness and fatigue and perhaps contribute to falls. Could you use high CBD or CBD alone? You could. It's probably less likely to help the pain, or you might need a higher dose. And look, often it's good to start at night time because any medication for pain can cause some sleepiness. Now, for some people, if they're not sleeping, well, it's actually a plus. And often people find they sleep better. If they sleep better, their pain perception is improved the next day because they've had a better night's sleep. And if they've had a better night's sleep and their pain's a little bit better, then they might be a bit more active during the day and hence they sleep better the next day. So it can be a virtuous circle. So after a couple of weeks, she's a bit better. The pain's not gone, but she's sleeping better and the pain's a bit better. So we're nudging the dose upwards. And after 6 weeks, she's on 1 ml of the oil, which is 10 milligrams of THC and CBD. And that is not a maximal dose. One can go higher than that. It's unusual. One has to go much higher than 20 milligrams of THC and CBD, but sometimes one does. She's sleeping better, pain is less, and her quality of life is better. So she's having a better day. And that's typically when people are on medicinal cannabis and it is helping, they'll come in and say, I feel better. Absolutely. And sometimes, relatives, children or grandchildren or partners will come in and comments will include less grizzly, happier, complaining less, less tense. There's a whole lot of different terminology that essentially says the person is feeling better. It's not we've not eliminated their pain, not necessarily sleeping 8 hours like a baby, but overall there's that global improvement in quality of life, which is the aim of treatment. It'll work for everybody. Maybe the dose isn't sufficient. Maybe it's not getting absorbed. Sometimes people are more active and they find that they reach their same pain levels because they've been doing more to get there, and that's a trade-off. And as I mentioned, observations of others can sometimes be helpful. You can always adjust the dose. There is a point where you pull up stumps, like with any medication. no absolute guidelines on changing formulation, but the more one goes with prescribing, the more one gets a little bit of a feel for it, if you like. Similar with blood pressure medications. If it's not lowering somebody's blood pressure, there's a point at which you either add in something else or stop or change. Same thing here. After about 8 to 12 weeks, if we're really going nowhere, then there's not a lot of point in continuing. That is long enough. It does take a number of weeks to get there. And then it's always a discussion with the individual. Look, do you want to try something else? Do you want to keep going? Have you sort of tried it? You've had enough. There's no absolutes with any of that. But it is the case that probably 70 to 75% of people will get a reasonable enough a response that they think it's worth continuing, and others won't. All right, frequently asked questions. Is it covered by insurance? So some private health insurers do. It's not on the PBS. HIF provide a rebate. AHM, I'm not endorsing any of these companies, provide a rebate. A number of others do as well. People just have to check with their insurer. It depends on their table and who they're with. Any doctor can prescribe. Obviously, it's useful to have done some training or know a little bit about it. But any doctor can, and nurse practitioners in certain circumstances can as well. Yeah, look, it differs by state, but there's much more alignment than there was in years gone by. Can people travel? Look, you can go interstate with medicinal cannabis scripts. Typically don't suggest people travel internationally, notwithstanding a lot of countries you can buy it there, but it's different to buying it where you are versus bringing it in. And I certainly wouldn't take it into Singapore, although having said that, I did have a patient who was prescribed and notified the Singaporean authorities and got a letter saying, yes, you can bring it in for your personal use, and I was pleasantly surprised. You had a question?
Yes.
Yeah.
Through some.
Yeah.
And doctors go, wow.
If you're transiting, same in the Middle East, if you're transiting and not clearing customs, quite different to entering the country. If you want to bring it into the country, then yes, you want to have permission. Otherwise, it may not end well. In fact, when we came back from Thailand 2 years ago, we went via Singapore, and on the plane, they did make an announcement. Obviously, we're coming from Thailand, that bringing cannabis into Singapore is an offence punishable by penalty up to and including death. So yeah, Thailand and Singapore very different. So if you get permission, good, but certainly if you don't, then no. But interstate's not a problem. Can patients drive? As I said, if THC is detected, then they can be in trouble. It's estimated that 90 to 95% of people who've been prescribed THC products just go about their daily business, and not that many get pinged, but there is a risk. After about 8 hours, it's unlikely, not impossible, but unlikely to show up on roadside testing. Urine testing, it can show up days later. So that is quite different.
In regards to risks.
Yeah. Again, it's an old adage, says the law is an ass. Problem with cannabis laws is that the laws still effectively treat it like an illegal substance. So the laws, the road laws really got nothing to do with road safety. They are to do with de facto prohibition. So they can test people at the side of the road, typically, and they test up positive, then they can do, search of their house or whatever. They've got due cause. So yes, the laws still treat it as an illegal substance. And as I said, an upper house committee looked at it here. A committee looked at it in Queensland and New South Wales, and also I think also in South Australia. And it's not as if the government hasn't got the numbers to change if they wanted to. And Cook, I've heard him say in a talk, oh, look, I'm very supportive of medicinal cannabis. Well, no, not in my opinion. But yeah, exactly. Like, how hard can it be? And particularly in the last parliament, you could do whatever you want. So what's stopping it? Not that the other side's any more supportive, but they at least don't pretend. But people do it and get away with it, rightly or wrongly. I think over the years I've had 2 people pinged. One was working for a mining company. He'd been on it for 2 years, and more or less said to him, look, you either stop or it's your job. And it's completely unfair and it is discriminatory, but it is what it is. And there's a drivechangemc.org, it's run by a retired magistrate. He's trying to get the laws changed as well. But yeah, if you're impaired for whatever reason, and they say that it includes hay fever tablets you can buy over the counter, then you shouldn't be driving or operating machinery. There are some sites, the ANZ, I can never remember the acronym, Australia, New Zealand College of Cannabis Physicians. That's it. Marijuana and ANZCCP is run by a doctor in the Blue Mountains, or Hotsman, she's lovely. Marijuana is run by a doctor also in New South Wales, Teresa Towpick, she's also lovely. Sorry? Yeah, and they run webinars for health professionals as well. So they're very good. I think they're running a seminar, a conference in September. I think it's next month in Manly. And ANZCCP have an annual conference in May. I think it was on the Gold Coast this year. Green Choices is unfortunately down at the moment, as I'm informed. It was also a resource portal for health professionals. But it'll get back up in due course. So look, medicinal cannabis has a role in certain conditions for certain patients. Now, I've spoken a bit about the knockers and the naysayers, but at the other end of the spectrum, you've got the people who say it's a cure for everything. No, it has its role. It has got a good safety profile. It's a lot safer than a lot of other prescription medications. Some people get a good response, some people get no response, everybody else is somewhere in between. So it does vary. Quality of life is the key. Look, the applications are pretty straightforward. It didn't used to be the way, but now they are. And yeah, it's an evolving field. We know a lot more than we did 5 years ago. In another 5 years' time, we'll know more than we know today. Happy to take any further questions. Yeah.
I was just wondering if cannabis has any contraindications with prescribed medications, like for example, like alcohol as well with medications, but any
Okay, drug interactions. Not contraindications. It's additive with any other medication. So with pain meds, it's going to be additive. People are on pregabalin or an opiate or tramadol, then yes, you add in medicinal cannabis, it might increase the sedation or the wooziness. So you might start at a slightly lower dose. People need to be a little bit wary with some of the blood thinners that if people are on for heart conditions, warfarin in particular. There's a test called the INR, which needs to be done with the newer, what are called NOACs. Again, maybe sometimes starting at a slightly lower dose and watching for any bleeding or bruising. But other than that, I think it can interfere with a very old asthma drug called theophylline, which hardly anybody uses anymore. So no, there's no, theoretically, if you go, there's a site called drugs.com, and if you put in either cannabidiol or THC and drug interactions, and throw up a whole host. But clinically, it's mainly with medications that have a similar effect. Particularly a sedating effect, but a lot of the others are much more theoretical than practical. Yeah, there has been some, wouldn't say a lot, but yes, it can be useful in ADHD. And and obviously we're talking about pain tonight. The other one where it can be very useful is behavioural and anxiety issues in autism. A good mate was a professor of psychiatry. He was from Argentina. He's gone back there now, and he had a fairly specialised practice in adult autism. And when medicinal cannabis was being legalised, he was very, very positive because you reckon about 90% of his patients used cannabis illicitly because it just made them feel a bit better. So yeah, ADHD, yes. Autism, not to treat autism, but for behavioural issues, yeah, absolutely. And the result, and there has been a reasonable amount of work done on that using CBD. So that's a CBD alone treatment. And the results can be quite dramatic. Again, not always, but it can be quite dramatic in some of these kids.
I'm shocked. Clients how many clients I get that say, oh no, medical cannabis. I don't just want, tell me why, because I'm not their doctor. But the amount of people that say, oh no, medical cannabis, so it's free and yes, they'll use it, I'm cruising, I'm okay, and I'm kind of flustered to be honest. And because I'm not informed, I don't really feel it's my place to actually question. I'm thinking, how did you even get that and why? It's really common. And a lot of my clients are neurodiverse. So whether it's ADHD, autism, I think that it will ultimately kind of be
Look,
a,
and anxiety, probably anxiety and insomnia, probably two of the really big.
because some people that I know personally have said, oh, you're filling this questionnaire and the answers are basically good. So I know that is a thing and we don't have to talk about that, but that's apparently how they get in.
Yeah.
But then once they've got it, and they just save money. I suppose psychologically, it decreases financial stress. Maybe it doesn't feel as illegal, so maybe there is alleviated stress in some side areas. But I'm a bit.
So at the start, go back about 7 years or so, our medicinal cannabis was not stupid expensive, but expensive, and certainly it was a lot cheaper to buy it on the streets. What we've found, surprise, surprise, as production cranks up and it gets more common, price goes down. And we're now at a stage where, as I'm given to understand, the cost medicinally is comparable and possibly cheaper than street. And there's a reasonable subset of illicit users who are using it to self-medicate. There are some who are using it for their own reasons, but what's sometimes be called, I don't like the term, it's the one that's used, the med rec market. So they're using cannabis illicitly, but to help sleep or anxiety or PTSD. And they have increasingly gone into the medical market. Now, there are a number of online telehealth clinics that do medicinal cannabis, and some of them are very, very good. Some of them are very dodgy. And the dodgy ones essentially, yeah, how are you going? How do you feel? Oh, I'm a bit anxious. Right, how many scripts would you like? And it's been alleged that, I don't know if anybody does this, that there was one doctor wrote about 20,000 scripts in a 6-month period, which I don't personally quite understand. Their story, which still, explains a tiny bit, but not the full, is that, yes, there are some supply issues. So, all right, I don't know which product you're going to be able to get. So I'll write you 10 prescriptions and you can get the one filled that the chemist has. Yeah, I don't. There's a little bit of that, but it doesn't explain the number of prescriptions.
Like because of pain or aside from.
Look, most of these ones, are going to be for pain or for anxiety. But the other argument that the issue that the medical regulator APRA is now looking at is, have these people been properly assessed? And there are also allegations that people go online, they do a questionnaire. And look, when I see people in the surgery, they have to do a questionnaire before they see me as well. It's useful. You get some background information. It does save you some time. It's good. You still have to make an assessment when you see them. It can't just be the questionnaire. There does need to be some degree of verification, especially if you've never seen them before. And it's claimed, and I suspect it is the case, that in some of these instances, it's pretty much, yeah, good, anxiety, yeah, good, what do you want, how much of it?
Scripts, but that's a different story. I am curious, what psychological therapeutic interventions are most used or effective for pain management support?
Look, I think there's CBT seems to have a role. Mindfulness seems to have a role. Look, if there are some underlying issues, particularly with injury, if it's trauma or PTSD, then counselling can have a role there. They're probably the main ones. And there are some self-help programs like Beyond Blue and Black Dog run some online programs, and some people find those quite useful. Institutional, like it's the bureaucracy. workforce, probably not a big issue in terms of prescribing. And not everybody has to prescribe. So like I'm in a practice with about 8 other doctors, and look, any of them can prescribe, but typically in a multi-doctor practice, somebody will have an interest and the others will be referred in. I'm in the same practice as a guy who does a lot of skin cancer work. I don't really do much of that anymore. So no, workforce not an issue. Look, bureaucracy is a bit of an issue, but it's less than it was. Probably negative sentiment from groups like the AMA and the college GPs, sort of more or less telling doctors not to do it because they know there isn't any evidence and no, it doesn't work. Well, tell that to the people who feel better that it doesn't work. I actually find it quite insulting and demeaning. So a lot of doctors have been quite scared off, but what happens is a few start and a few more happen, and then patients come back and say, oh, I saw Dr. X and he prescribed medicinal cannabis and I'm feeling better. And by the time you're seeing that for the second or third time, you start to think, well, maybe I might look at this as well. So yeah, access probably not anywhere near the issue it was 5 years ago, and not as much 3 years ago. In fact, with some of these clinics online, it could be argued that it's almost going the other direction, that is too easy to access. I think the pendulum has almost swung to that point, and probably does need to be, I wouldn't like to say tightened, but yeah, I mean, after 2.5 years of being told they need to do something about the cowboys, they formed a rapid response team, and after another 15 months, they finally did something. A little bit late, but never mind.
Okay, but are there treatments that get extinguished? Like, do you prescribe and then that does its thing and then we're finished prescribing that now? Because you said some people do get that benefit.
Yeah.
Do they then require it long term?
Look, if it is chronic pain, if the underlying cause hasn't gone away, then they may need it long term. Some people do find that they just get less pain and they can manage it in other ways and they don't continue. But it's not for injury or acute pain. So if you've got an injury and it's going to heal up, then no, that's not where medicinal cannabis comes in. If you have got chronic pain, can it meander its own way? And if for other reasons there are improvements and you find you don't need it, then you come off it. And that certainly does happen. The cessation or stop rate is reasonable. And whether that's because of cost or because of access or because people just get better, I don't think anybody's really looked into that. But no, people, other than, so again, this issue of reliance, might people sort of feel, oh, this is making me feel better, and if I stop it, I'm going to get worse. Well, if they stop it, they may well get worse. And I've had people over the years say, look, I stopped it, I didn't know if it was helping me or not, and my pain got worse. And that probably is no different to, I was on my diabetes medications, my sugar came down, I stopped taking them, my sugar went up. Yeah. Occasionally stopping for a few days can be helpful. There's a theory that resets the receptors, and that's a bit like switching a computer on and off. Don't typically see, as against with opiates, that there's a constant increase in dose. Once people reach a dose, they seem to be quite good with that for, look, I've got people now been going for some years. So no, there's not this constant ratcheting up. Can the underlying condition worsen and one might need to increase it? Same sometimes with blood pressure. Blood pressure's been steady, but now it's going up. We need to increase your dose, but not routine.
I think medical legal challenges with people on medicinal cannabis driving and then getting caught. Is there a procedure that doctors have to follow to actually explain to the patient that they're not allowed to?
They need to know that if it's detected in their system, they can lose their license. And part of the pre-questionnaire that I have does have that in writing, and people have to sign it in advance so that they know that they've been told and that they're aware. Yes.
Yeah. You disclose that as like a lot of other medical conditions, you disclose it, and you need to get it checked, let's say yearly before you can drive, like secondary with that. To be clear, using cannabis.
That's a good question. Probably not, because if people did, they'd all have their licenses taken off them. So I suspect I suspect nobody does. So no. Interesting point. All right. Well, look, yeah, it's an interesting area, and yeah, the laws and the laws and the medicine are somewhat in conflict. But on the ground, somehow, for the vast majority of people, when you look at the numbers of prescriptions and you look at the numbers of people who've been caught, um, it somehow works.
Yeah.
All right. Well, thanks for everybody for coming along. Thanks for your questions and your participation.
Lots of things must have happened in Blue. People had other things. Anyway, thank you so much,
All right.
Dr. Joe. I do appreciate it again. I'll just stop our recording.
Question, what's your blog about, or your podcast?
Oh, look, just anything that comes to mind.
Is it medical or is it personal?
It's medical.
Yeah.
Yeah. But probably more lifestyle and script. Yeah, look, I'll see different topics or different studies or papers or not medical as in like scientific, but things that have come out about different topics of diet, exercise, sleep, stress management, policy, and yeah,
Thank you.
have something to say about it. I think we're up to episode 106, dropped yesterday, so we're chugging along.
Stop recording. There you go. Bye.